Hello and welcome, everybody. Thank you for being with us today. We are broadcasting live from at least a couple places I know of, where I am in Florida and Minnesota. I think our friend Jason is in New York or Connecticut. I don't know where you are, Jason.
New York.
Yeah. And so thank you all for being with us today. This is all Jason's fault. He's a friend and a stellar human being. And so I'm glad to have known him for several years. And he's brought several really interesting opportunities in this space. And there's another one you're about to hear about today. So as usual, thank you for spending your afternoon with us today. We have about an hour. We've got lots of people that are dialing in. And I would encourage you, and we would love for any questions to put in the chat box or the Q&A. You guys are all Zoom familiar by now, I'm sure, but we'll welcome any and all questions, and we'll get to as many as we can as we go along here. We're going to have some short introductions and then a formal presentation. And please feel free. We're not going to wait till the end for questions. We'll just take them as we can throughout the process. And just for the record, this is being recorded. Not that we can see or hear you, our dear attendee friends, but just so you know that at some point, if you wanted to review it or you wanted to share it with others that would benefit from knowing about this opportunity, aside from us putting you directly in touch with the Triopsy folks here, you could potentially share that with others that would benefit from it. So with that, I'm going to hand it off to Brad and do some introductions. And here we go. Thank you all for being here today. Brad, welcome.
Yeah, thank you, Arthur. Good afternoon, everyone. I'm Brad Busher. I'm one of the founders and the principal shareholder in this company. My colleague, Todd Anderson, who's on with us today, and I run a private merchant bank, which were the entity that really had covered this. Like you, we not only raise money, but we make investments as well. So we tend to take a kind of a broader view and a more cyclical view of how we roll things up. Today, we're going to be sharing a discussion about this project of ours called Triopsy, which in essence is a new way to diagnose prostate cancer earlier and more accurately using a simple modification of some old devices that haven't changed in 35 or 40 years. There's a crying need for it. It's still the #2 killer of men, over the age of 40, really, right behind heart disease and head of lung cancer. And there's a big backlog of need as a result of course, our friends that created COVID. And as a result, we've taken a little longer to get this to market. I really stepped in here in 2015. We were ready to really launch the beginning of 20, and then COVID hit. So here we are now at the beginning of the second quarter of 2021. With that said, I'd like to introduce my colleagues. Jason Rifkin is our Chief Operating Officer, and started out as a consultant to the company and has a ubiquitous background in med device as well as biotech and biopharma space. My colleague Todd Anderson is with us, who's my CFO and is the CFO of this company currently. And the other fellow with the actual brand behind his name is Paul Arunga, who's our Vice President of Theranostics, which really means that he's in charge of everything that we're not. He's involved in the engineering platform and has worked in the space with two of the original founders going back to 2005. So with that said, I guess I'd like to launch into the project, Arthur, with your permission.
By all means, carry on.
Yeah, so Paul, if you'd advance to the first slide. So what are we really doing here? We're trying to improve the outcomes for men that are going in that have to have prostate biopsies done. The problem with these is that the technique that's been used and been around for 35 years, when they first invented the PSA, uses an approach through the rectum. It's called a truss, and the needles do not have the depth, breadth, or bandwidth necessary to provide enough tissue to really do the study, nor do they know the precise locations. So what we created here was basically a 4-part set of devices. It's a piece of software that guides the mapping of the entire gland. It's a proprietary new needle that takes a longer core sample of tissue, an actuator, or what others euphemistically call the gun that drives the needle. And then last but not least, and probably most importantly, is we came up with an entirely new way to manage tissue from the moment it's taken off of the needle bed core all the way through out of the OR, down in the histology, microtome, and then ultimately onto the pathologist slide. We've been at this now for 5 years. This gives us some, some comfort that, we have some pathways that we know we're clear on. There's plenty of predicates for this under the 510K track, and we expect to be fully launched and commercial at the end of the second quarter of next year. Can I have the next slide, please? So what are we really trying to do? I'm sure some of you have heard of this term, meaning the unmet need. The problem with this is that there's a big miss rate when biopsies are done, whether it's in the doctor's office or in the OR. About 50% of the men walk out of there and they either don't know what they have, or they don't know where it is, or they miss it altogether. And as a result, there's too many men that are being overtreated, and there's a fair number that are being underdiagnosed. And the goal of this whole project is to try to synthesize that to give better outcomes to these people. As you can see from this slide, we are approaching this with an analysis of how to take the gland, how to set it up so that we can biopsy it in its various different components, and try to eliminate some of these issues, from false negatives to the very simple fact that the current needle is too small to take much of a tissue sample at all. The competitor is MRI, has not been very consistent in taking samples large enough, or finding samples large enough to get beyond about 1/2 to 1 centimeter in size. Most of these lesions are smaller and quite deadly. Prostate cancer is a multifocal disease, and there's a very low chance of catching all the tumors if you're only taking 12 core samples, and further, you don't know where they are. And then if you do get treated, and this actually happened to my brother-in-law last year, which advocated this for me, is that they said he had a Gleason, which is a standard measure of score to determine severity, of a 6, maybe a 7. He decided that, well, that was too high for him, even though it was probably a fairly low indicator. Went ahead and had his gland taken out, and sure enough, when they did the whole mount resection afterwards, found out that the kind of cancer he had was the kind that was indolent, and he could have lived with until he was 120. And he's had a number of very sad, if you will, collateral effects from it. He's been incontinent, he's had erectile dysfunction, and he actually came down with Guillain-Barre's, which he doesn't necessarily directly relate to this, but the effect on his autoimmune system was profound. There's 100,000 of these prostatectomies performed annually in the US, and it's our estimate that maybe 40% of those are unnecessary. So what are we really doing here? We're trying to provide hope for men that haven't had it before. Next slide, please, Paul. So what's our solution all about? We're going to change the way it's done by making a change to the existing procedure for both the truss and what they call the transperineal approach. And for those of you that are not in medicine, the truss stands for transrectal, and the transperineal approach is that gap between a man's scrotum and the top of his anus that you would go through the skin externally to get to it. And the gland sits behind that, in between your bladder and your rectum, in kind of a longitudinal shape. This is designed to, increase that diagnostic accuracy from, that low 40 to 50 to an excess of 90. Simple. How do we know that? Because we're going to frankly take more tissue out, which we'll show you here in another couple slides, and be able to plot that into a map. How do we get there? Like the Frito-Lay ad has ruffles, has ridges. We designed a needle that actually has ridges in it, and it can capture it and take it embedded in on the core bed after each sample is taken, and then transferred onto that pathology device we talked about. This really is going to ultimately, function as a personalized approach to cancer treatment for individuals rather than one size fits all. So if I could have the next slide, please, Paul.
Hey, Brad,
Yes,
would you mind if I asked a question?
go ahead.
Is it relevant, and do you know how much of the misdiagnosis, either way, positive or negative, is a result of the tissue sample handling chain of command, or that's not the right word, but chain of custody?
That's a very good question, Arthur. The first thing is, are they finding the tumor? And in this particular slide, which I'm going to ask my colleague Paul to kind of explain, because he helped put it together about what the limitations are of the current tech. So Paul, if you'd walk him through this, I'd appreciate it.
Wait a minute, I missed that last
It's on.
part.
You're on mute, Paul.
You're still on mute. All right, well, I guess I'll try to take that while he's working on it. In this upper right-hand box, you'll show that the longitudinal aspect of what the gland looks like. The current needle can only get to a certain part of the gland because of the transverse angle and also the core bed length, and the actual size of the needle is not adequate enough. What we're trying to do is we're trying to design this so that we can get to that apex area, which is in that block at the backs, where interestingly, I think the statistics are over 70% of the tumors are found, and be able to get and then find where those lesions might exist. Are you back on now?
Can you hear me now, Brad?
Yeah, we can.
All right. Sorry, my external microphone wasn't working properly, folks. My name is Paul Orongo. I'm the Director of Theranostics and the Engineering Project Manager here at Triopsy Medical. And as Brad was mentioning, this is kind of a nice slide that demonstrates our patented needle device. And what it really does is it allows the needle to reach the anterior portion of the prostate, which can be seen up here. I'm kind of doing a laser pointer around the anterior portion of the prostate. And the extended length will really capture a lot more tissue for the needle, which will give us a more accurate diagnosis. As you can see here on the bottom, we have a series of ridges that will actually help us to collect the tissue more accurately and will reduce tissue fragmentation. One of the biggest problems we see right now in prostate cancer diagnostics is the current needles have a very smooth surface, which you'll see in future slides. And this creates a lot of fragmentation of tissue. And what the fragmentation can do is actually, because of the differences in the density of the tissue, it can sometimes miss the actual cancer. So if you put the needle into the cancer, it can actually fail to select that tissue, or it can take a smaller sample or just kind of skip around the cancer tissue in general, which can lead to a inaccurate diagnosis. The cannula on our needle can actually also take an adjustable specimen. So it's not one fixed length, which we've seen in a few very small subset of companies that did come out with an adjustable needle. One that I can recall off the top of my head was from Bard, that was up to 2.5 centimeters. Ours will actually go to 5.6 centimeters. And the tip of the needle, which you'll see in future slides, also has the ability to reduce deflection. So that enables us to really hit our targets far more easy than the beveled tip, which has a tendency to deflect, and that is on the current needles that you see in the market. And the needles that we'll be coming out with will be 18 gauge for truss biopsy and up to 15 gauge for transperineal biopsy.
All right, Paul, next slide, thank you. So here's a side view of our new biopsy device. And this is novel, and these devices, I might add, I didn't call attention to it, all have patents that are associated with them. This is novel because it's got a control depth knob. It has a safety button that most of these don't have. It has an actual firing site. And most importantly is this highlighted piece here. It's called the depth setting indicator. Because the critical piece is we want to get to the back of the gland, but we don't want to go through the gland and end up in some poor man's rectum or in his bladder. This allows us to take, a smaller sample from the fringe area of, let's say, 1.5 centimeters, all the way up to 5.6. whereas the current one tries to take about 1.7, in reality is coming in at somewhere around 1.2 to 1.17 centimeters. This is also a reusable device because of its additional features, and therefore it's being designed with cleanability, sterility, and biocompatibility in mind. Next one, please, Paul.
Brad, 1 second. When you first started speaking with this slide, you said, and by the way, we didn't mention this, but it has, and I think others might have missed. Oh, you're the patent. That's what you were saying. Okay, got it.
Right.
I just didn't hear the word.
Yeah, I'm sorry. Yeah, we put the patent numbers on the top of each page, and a little later there's a slide showing the whole list of our patent portfolio. So here is a perfect example that I'm going to let Paul talk about, of the differences between what the old tech was and what the new is.
Thanks, Brad. So as you can see here, ladies and gentlemen, we actually can demonstrate our device here on the left, which is our Triopsy device, as well as the 30-year-old technology that currently exists in the market. As you can see on our device, I'll start off with, you can actually adjust the length of the specimen, and anywhere from 15 to 56 millimeters. And as you can see, this very long core bed that exists. And this long core bed enables us to take a very long, very accurate biopsy. And the teeth, or these patented ridges that we have, really does help with the tissue and enabling it to take a full core sample without having the tissue bunch up when you actually retract this part called the cannula of the needle. So during the procedure, the cannula will shoot over the core bed and actually sample a specimen of tissue. And when you retract the cannula, these ridges not only help to obtain a much longer, more unfragmented core of tissue, which improves diagnostics, but also prevents the core from being bunched up as the cannula is retracted, exposing the tissue when it's removed from the body and allowing it to be collected for final pathology. The trocar tip here, which is a 4-point tip, actually also reduces significantly the needle deflection rate as a result of firing the needle. I believe our average deflection rate was about 0.3 millimeters, which is extremely small, as opposed to with the beveled tip, which is what you see commonly on most biopsy needles on the market. And this beveled tip, unless you account for this while you're actually taking a biopsy, this will deflect significantly. I believe it's about 1.2 centimeter average deflection. So it can be a significant amount of deflection during the procedure. This smooth biopsy core bed, as you see here, I've witnessed well over 500 biopsy procedures. And one of the biggest problems we had during the procedures was either this biopsy core bed wouldn't even collect a sample, and we would have to go back and take it again and go and re-sample that area, or it would actually just have a significantly fragmented samples. So as we mentioned before, on this technology, the longest needle you can really get, it has about a 20 centimeter core bed length, and the beveled tip makes it far more difficult for the surgeon or the doctor to actually hit the target of interest. And many times they'll have to go back and reshoot that area just to try and get the target that they're interested in acquiring.
Okay, Paul, why don't you just keep going and explain the relative difference of this?
Okay, so within prostate biopsy procedures that we have today, some of the biggest problems we see are things called systematic and random error. The random error occurs as a result of sampling 12 samples around the prostate for a truss biopsy. Because prostate cancer is a multifocal disease, which means it occurs in more than one area, and the cancer grade can often be of varying grades in other areas, the random 12 biopsy samples, which sample less than 1% of the prostate, end up missing a significant amount of clinically significant prostate cancer. The systematic error occurs as a result of having a biopsy needle that is too short. So as you can see on the right-hand side here, this would be an image representing the shorter current biopsy needle that we see being used commonly in today's practice. And this area at the top is an area of cancer. Now you can kind of see there's a large purple outline with the green outline. These likely represent two different grades of prostate cancer. So on the right, with the 30-year-old technology, the systematic error occurs because the needle is not long enough to reach the area of cancer. We estimate that 25 to 35% of cancers occur in this anterior region of the prostate. Not only is it missed by these standard transrectal needles, but also MRI, one of the biggest problems with MRI is that this area of the prostate often is very hard to visualize under MRI. And so even if the patient does have a cancer in this area, it will often go undetected. So as we mentioned before, you can see this is really a non-adjustable needle, and it's limited to a maximum of 20 millimeters. If you look at our needle, our patented needle system, you will see that this will help reduce systematic error because we'll actually be able to sample larger portions of the prostates. We'll actually be able to get into this anterior zone, and this cancer would have been found as a result of just using our needle. The needle will be adjustable up to 56 millimeters, and it will really help us find more of these tumors, probably earlier as well. So some of the biggest issues with prostate cancer with these underdiagnoses can lead to a significant increase in the prostate cancer mortality rate. We're actually seeing that right now over the past several years. The mortality rate has actually gone up. And this is probably a combination of lack of PSA screening, as well as issues related to this 30-year-old technology.
So Paul, I think others might be thinking the same thing. Can you jump back one slide?
Sure.
Okay, real quick. And this is not to be combative. It may sound this way. Why wouldn't the incumbent technology just make a longer needle?
That's a very good question. I mean, why haven't they made a longer needle? I think a lot of times what we get is many companies have a very strong engineering focus, but they lack a focus in public health and epidemiology. So they are coming out with something that is similar to what exists in the market, but really we needed to have some pioneers like some of the individuals at Triopsy who are not only physicians, but also excellent experts and know a lot of individuals in the engineering field to come up with a design that would actually combat this problem, specifically in prostate cancer. So that's been my personal experience, and that really combining the expertise of individuals from various different backgrounds and understanding what the current problem is and developing solutions is something that Triopsy really has done an excellent job at addressing.
Arthur, the real answer to that question is that we tried, with the longer core sample of tissue, and frankly, it didn't work because it's like a, if you will, like a spaghetti noodle that's real tender, and it becomes almost like an accordion. That's where the idea of putting the ridges in there that holds the tissue in place.
Yeah, the ridges act like a barb, right?
Correct.
Yeah, super interesting. I can see
they
that.
Hold the tissue intact, and the next slide gets to the real core of all this. So what is the value of that?
Yeah, so you may want to wait on this, but let me ask you whether you do or not. We have a two-part question. Do you take more than one tissue sampling during the procedure with the Triopsy needle? And what are the pros and cons of sampling a larger quantity of tissue from one spot in the tumor versus taking multiple samples from different locations in the tumor?
Well, the answer to that question is we take quite a few samples depending on the size of a man's gland. I'm going to let Paul answer basically that's a safety and risk factor analysis, which we got plenty of data on. So, Paul.
So to answer the last part of the question, we'll take the same number of cores. So right now in the transrectal biopsy, you'll take 12 cores, but as you can kind of see in this lower section, we know that 60% of men over the age of 60 have enlarged prostates. This is a normal benign condition that we see amongst men. And so what happens is this part of the prostate becomes taller. They've actually done studies which have shown that if you give men medicine that shrinks the prostate, you'll actually find more cancer because you're actually creating a smaller target for your biopsy needle to hit. So at the end of the day, we're still going to take the same number of cores, but what we're going to do is have this technology that will enable us to sample the top and outside edges of the prostate more accurately. Now, eventually, we will plan on, when we roll out our 3D system, we're going to be able to completely saturate the prostate. And our research has shown that by doing this 5 mm saturation, that you'll catch greater than 95% of prostate cancers, as opposed to around 70%, if not lower, than what we're getting today. So very good question. Doesn't require more biopsies, but it will certainly find a lot more cancers. And I want to also end this by saying I had shown this technology to many urologists, and we're seeing about an 87% rate of urologists around the country who are very excited about using this technology. One of my favorite quotes comes from Preston Sprinkle out of Yale, and he is the director of urology there. And he essentially said that if he had this technology today, he would use it tomorrow. So it's something that is going to significantly help prostate cancer diagnostics.
All right, number 9, please, Paul. So this is basically the secret sauce of the whole project here, ladies and gentlemen. And that is that it turns out that this unfragmented piece of tissue is extremely valuable for a number of different reasons. One, so that we can see somewhere along that whole linear line where the lesion might be, because really at the end of the day, and you'll see from another slide here, what are we doing? We're going to end up having a model to show exactly where it is. So this will be the first time that you'll actually have a target that you could then, be eligible for what they call focal therapy. But instead of, killing the whole gland either with radiation, cryotherapy, or surgery, you'll be able to actually target where the lesion is itself. But beyond that, the other value of this is to really move forward the cause of diagnostics in medicine. They've been, looking for a way. There was a problem that didn't have a solution to get more consistent tissue samples. And this disciplines the surgeon, the med tech specialist, the tech specialist, and the pathologist to all manage the tissue in the same way. And now you're going to be able to, for the first time, actually use the algorithms that are necessary to be able to then do the predictive stuff to find out if we're missing something or not. And that has a significant, value add here as we go forward. Lastly, it's going to end up, we're going to be with more excess tissue. So there's a whole additional thing for molecular studies, genomic work, and someday immunotherapy work. This, by the way, solved a bunch of problems that we didn't know we intended to solve. It has the whole transfer issue that we talked about. Especially specimen provenance has been a major issue. There's too many errors that are happening in the ORs and labs around the country, and with a simple barcode or Cupid code now that's going to be tied into the patient record identification system. This is going to eliminate a lot of steps because it's going to be self-sealing. We designed it to have a fold where that you could then manage it, and the human being doesn't have to touch it anymore. And once it's placed in the vial of formula and transported, instead of having 20 vials that you got to either write on or put, if you will, the printed labels on to keep track of, it's all going to go into one, and they'll be able to scan it and do that. And then once that's done, this is going to increase the throughput dramatically. And we did not intend to do that because our original goal was just to get enough tissue so that we could see where the lesion was in this long line. It turns out we have all these other value adds we're going to attach to it. Next slide, please. So this is what I was referring to when I said, for the visual representation of what we're going to do. When we ultimately introduce the mapping, you'll be able to see that we start in the upper left-hand picture here of a grid that basically lays out the case. And so imagine each one of those grid points would be theoretically a sample location. The second slide to the right shows, on a rendering view of what the gland tissue sample will look like. That's an actual ultrasound slide superimposed with our needle in it. And then once it's done, it's taken off and it's gone through histology, through microtome, and then back onto the pathologist slide, and they look at it, and then it can be uploaded. Now you can see a visual 3D representation of where that lesions are. And this is where you could actually get the targets. And now that between yourself, your surgeon, you could be making decisions on, what really optionality do you have? And that's a first. Nobody else has come up with this yet today, to our knowledge. This is a patent pending project. We've had IP granted on all the other parts, but we've got a fairly interesting application that's in its late stages of being vetted by the USPTO as we speak. Next slide, please, Paul. So, you know, we have to have a slide talking about the scope of the opportunity. The number of biopsies worldwide is about 3.5 or 3.2 million. And 2021 estimated to grow to just under 3.4 million in 2023. The annual number of biopsies we know are being done in the US dropped somewhat due to COVID, was about 1.2 million. That year it was down to 910,000. The rest of the world was approximately, and when we say the rest of the world, that's the known world that actually keeps track of this kind of stuff. That does not involve companies like, you know, South America, Africa, or anything that's going on in India. And to our knowledge, the Chinese and the rest of Asia is doing a pretty good job. But we know there's real hard data that's here in the US, Canada, Mexico, and also in Europe.
So this would be a good spot, if you don't mind, because this is a question that is relevant to the slide. Our friend Paul says he's curious about the estimated valuation of the company Triopsy is if universally adopted. It seems that the standard is BARD Magnum. Sorry, I don't know what that is currently. What is the value of BARD, which may give an idea of what the company could be worth? And in the spirit of full disclosure, being that this might be taped, we're not in the business of suggesting public company shorts or longs, but
that's a good question.
Our friend Paul suggests we might want to short BARD.
Yeah, BARD was acquired several years ago. It's now a subsidiary of Becton Dickinson, and it's frankly they were pretty active in the market. They were out making acquisitions, and one of our predecessor colleagues actually started a company that he sold to BARD in about 1994, 1995, and we thought that they'd be a good, you know, benchmark for our future. I can tell you that this is going to be a paradigm shifting tech. We expect that it's going to get a lot of interest. We don't necessarily think it'll ultimately be from an existing urology, you know, based project. It could not, because the real value in this thing is all going to be in what you can do in the treatment end of it, and that is a whole different bailiwick that we're not involved in. Matter of fact, we got an ironclad rule in our company. Thou shalt not, I repeat, not make an estimate of who has the best ablation technology. We're merely the gun sight manufacturer, designer, and implementer that's going to go on everybody else's tool, whether it be for surgery applications, whether it be for cryotherapy, whether it be for brachytherapy, radiation, and some of these other new novel things that are coming out. RF, there's HIFU, there's you know, a number of different procedures that are out in the market today. We just want to give them the best target possible, and frankly, not alienate any of the existing companies that are working hard in that space. This is going to have ubiquitous opportunities then in the other even bigger market, which is interventional radiology. And for those of you that don't know this, interventional radiology basically covers all other tissue modalities. And again, they're all done, you know, on tissue samples from all the other organs, whether it be lung, liver, spleen, kidneys, pancreas, thyroids, sometimes even, you know, heart tissue or heart sac, you know, pericarditis is a difficult diagnosis to make without taking samples in that area. And we believe that our device will have, shall I say, applications across that platform as well.
So if you don't mind, two things. One, the reason why I can run from Rona and sit in the sun is because I figured out how to monetize data. The data collection part of this, since you have this unintended benefit of carrying the biopsy material, am I going down the right path here? You're going to have all this anonymized data,
Yeah, and so I think this is a good opportunity, Arthur, for me to introduce the guy with the headset on, Fred Mitchell. Fred is on deck to become our CEO. He's currently finishing up another project and really can't start until the end of May, early June, but he's been deeply involved in this company. He came out of one of our prior engineering firms that worked on it. So Fred, I'm gonna kind of let you feel that question, introduce yourself here briefly.
Yeah, thanks, Brad. Thanks, Arthur and team for allowing us. So you are dead on. It's not just that we can provide better diagnosis through being able to sample a greater portion of the gland, but now that we have all this information, how does that get to the physician to improve patient care? You saw earlier the image that Brad and Paul showed of the prostate. There we go. So this is considered 3D mapping of the prostate. Nobody does this currently. We are on the verge of receiving, we assume we'll be receiving patents on this technology, copyright on the software, but this will provide data that no one's been able to even consider at this point. So while the longer bed length of the needle, the teeth on the needle allow us to get an improved sample, the IPS allows us to improve the processing and deliver a whole picture to the physician. It's being able to put all of that together in data that's going to really cause a leap in not only prostate, but other tissue sampling technologies and treatments. So Arthur, you're right on. It's not just that you have an answer, but what do you do with it? And that's where the door is wide open.
Super helpful. So thank you and welcome, Fred. I know you had another obligation, but thanks for jumping in here. We have one other question here. Isn't ultrasound used now to locate cancer and then use high frequency ultrasound to eliminate without being invasive?
The answer is yes. Actually, ultrasound does not a good job of candidly identifying the lesion. There is a new tech called micro ultrasound that's coming, but it's not quite here yet. They don't have it perfected. And as you may know from any of you that have practiced in the field or know much about MRI, reading an MRI is only as good as the radiologist set of eyes that are looking at it. Well, the same thing's true in a live sense because MRIs are static images, whereas ultrasounds are, of course, live. How that HIFU works is they've first done some kind of diagnostic, analysis as we are proposing to do here. We're merely tweaking an old tech to make it much more accurate. So now then, someone that practices in HIFU will know which part of the gland to ablate, which you then, to your point, Arthur, can be done non-invasively. I.e., you don't have to go through good tissue to get the bad and burn it, with external beam radiation, or have a bunch of other treatments where they're putting needles in and frying your whole gland up using RF or some other kind of ablation technique, or cryotherapy, which doesn't have the zone of ablation that tight just yet.
Can I add on to that real quick, Bradley?
Sure.
So people have in the past used ultrasound to diagnose cancer, but what they've actually seen in the research is that it's no better than flipping a coin at actually determining where the cancer is located. The sensitivity and the specificity, or the ability for ultrasound to actually locate and find cancers accurately, is very low. It's less than 50%. MRI, which is what they currently use to diagnose prostate cancer for imaging, has at very best about an 80% accuracy rate. UCLA recently did a study on men who were undergoing surgical removal of their prostate, and they did an MRI on the individual before to come up with a hypothetical, what we call focal therapy treatment zone. And what that means is they tried to guess where the cancer would need to be treated if you were only going to treat the cancer. And what they actually found out is that after they removed the prostate and sliced up the actual gland, a process known as whole mount sectioning, which is a gold standard, it will detect just about 98% of all cancers, is that the MRI actually missed the significant cancers in over 50% of cases. And in over 50% of cases, the cancer was located on the opposite side and was completely invisible to MRI. So that's a very good question. And this is why we do this mapping procedure with all of these different all these different biopsy zones, is because our research has actually shown that our mapping procedure will actually be as accurate as whole mount sectioning. It's equivalent. We actually found cancers that were missed on whole mount sectioning. So by doing this, not only do we provide a full 3D diagnostic image of the individual's prostate with the exact location of cancer, which no one else can do right now, we also are able to give the person a complete and accurate diagnosis, greater than 95% accuracy.
Super.
Okay, so the real meat of the matter is, how do we intend to do this? We're going to bring Fred on here. We're going to have a direct sales force. We're going to start with about 4 to 5 what we call research centers. We're going to make sure that the system and all the parts and pieces that we're working, and then we're going to roll it out in the U.S. only very slowly. And to answer, I think it was Paul Sanders' question earlier, what are these things worth? Well, we'll get into the exit issues a little later, but the definition of what a company is really valued at isn't so much sales. It's always about what they call quality of revenue. And the definition of that is it from legitimate organizations. It's not just, one-off, field, or you have one customer that's the only one you do business with. And is the gross margin greater than 85% across the board, after COGS at the top level? And both of those answers are really in the fulcrum of when we did the financial model, how we roll this company, how we intend to roll this company out and roll it out. So with that, we're going to, we've got a commercialization expert kind of identified. You don't bring them in because they're expensive, human beings, and bring in a whole team to do it until you're really ready to go. We're going to start very slowly to make sure that we've got, the initial launch covered, and you want to make sure all your systems are in place. I've been involved in a lot of different deals, and they blow up if they try to hit the hockey stick too carefully and too quickly, or not very carefully and too quickly. And that is, not one of those rookie mistakes we intend to make here. We have identified all the leading academic institutions. We'll show you that on our science advisory board slide here in a moment. And then ultimately we'll bring in, about a year later, we're going to introduce the software solution. And then that's when this thing will get kicked off into high gear. This is a $3 million, basically what we call B2 raise. We're going to need about another 12 million once we get into commercialization to finish the rollout in the US. And then if we ever get there, we'll be rolling it out in the rest of the world with about another 12 to $15 million raise, on behind it. We have insurance CPT codes for all this, and all insurance companies in the universe are currently reimbursing for these procedures. So it's got all the right aspects, and there's decent margins in this, if not excellent margins. And it's going to be, it's innovative, and it's going to be disruptive. And we are likely going to be going to market and selling it as a kit that'll include 1 or 2 needles. It'll have the pathology piece attached. The tissue transfer block will all be part of the kit. And once the software then gets rolled out, that'll be on a per click per use. And the other question I think that was asked earlier is of note, there'll be a fair amount of data that we're going to be collecting. For some of you that live around the world know that Minneapolis is also the home of a large kind of insignificant company now called United Healthcare, and their division of Optum is the world's largest purveyor and collector and capture of data. And I know the principals there very well, and they basically have told me anytime you can collect something that's got data that we can use to predict future outcomes, that's valuable. And accordingly, our business model will be built around that ethos. Next slide, please, Todd.
Listen, I'm sorry, guys, but I had a girlfriend that once said, okay, that's nice. Can we talk about me now? So I sold my first company, United Healthcare. And so I totally get what you're up to, and they are the right spot. Good for you guys.
Well, Steve Helmsley, who just stepped down, is on an advisory board with me on another matter as we speak. He's quite a guy. He's the one that really took it from, a relatively big company to a phenomenally large company here in the last 15 years. Here's a slide that shows our patent portfolio. So we hold patents in multiple different jurisdictions, but of all the primary components. So we've got one on the needle, actually two on the needle, two on the actuator, or what we call the gun, and we have this pending one that's in the late stages now, a non-provisional pending on the software. Getting software patents is typically not done. Most people go out and trademark it, but we have something that was very unique here, and decided that it didn't hurt. We were going to go out and try to patent the system that we're putting together, and hopefully that'll be done later this summer. So take us to 14, please, Paul. So what are we doing here? We're doing a very small raise. Frankly, this is something that we usually don't do. We're doing a pari passu with ourselves. To date, there's about 9 million in the company, and I put up with my partners in various different entities about 60% of that. The pre-money on this deal is 8, and the post is 11.8, and we expect to get a fairly large lift once we get ready to go through the FDA clearance and finish the balance of the engineering process. And we would hope that those of you that may be listening will find something like this pretty attractive. We consider ourselves to be a late stage development company that's got not one but two different sources or slices of the apple, maybe 3. And long term, the sum of the parts will likely be worth more than the whole. So if you could bring me to 15, please, Paul. Here is a list of our key managers. My partner, Deborah Whitman, couldn't be with us today. She and I have been in multiple transactions together over the years, and she's been a partner of mine in a number of different businesses, and is currently sitting as our chairwoman of the board. You got myself, Fred, who we've introduced you to, Paul, and one of the other founders that's a key guy, he's also a director, is E. David Crawford. He was Paul's mentor for years at the University of Colorado, and truly one of the innovative leaders in urology in the U.S. He's published over 1,800 papers and has got at one time sat at virtually every one of the major biopharma science advisory boards. Let's go to 16, please. And then you got Todd here, Jason, who's on the phone, another one of our medical founders, Scott Lucia, is a pathologist who practices at the University of Colorado. A good friend of mine, Jim Louisian from Boston, who is the managing director of Boston BioVentures, is an board observer. Another business partner, Jim Sankovitz, came out of the oil and gas business and has been responsible for most of the formation stuff of our various different transactions. John Harper is a good friend and a partner in a number of different transactions, runs an investment advisory firm in Las Vegas, and they have their own private family office. And then we have another guy who does med tech early stage investment, Michael Montag, as a director and one of the lead founders in our company. 17, please, Paul. So here's a list of our science advisors. All of these people were consulted. We've had a couple of formative meetings with them, and they've all had collaborative efforts in advising us on the tech. Matter of fact, the majority of them came to us after this all was first conceived and said, why don't you just introduce us with that new needle? That is a major paradigm shift alone, let alone the whole mapping thing. And ergo, we listen to them. Sometimes, you got to listen to actually advice you get from people. And ergo, why we're going to introduce a trust compatible needle first and then bring on the rest of the mapping piece. The only entity that's of not major significance that's not sitting on this board right now is or participating with us is MD Anderson. because they don't sit on the science advisory boards unless they own the tech or license the tech. However, they've expressed a lot of interest recently in what we can do in the whole field of AI with the pathology piece, and I'll be expecting that we'll be doing something with them in the next year or so. So what is the basis of the investment thesis? This is a disruptive, innovative tech with a significant unmet need to diagnose cancer earlier and more accurately. It's targeting a well-defined market with accessible channels of distribution. I might add that COVID has, killed a lot of small companies, caused us to have to put this whole project on hold. But what it did do is it built up an unbelievable amount of demand that's going to be coming to fruition right about the time when we're going to be hitting the market, because there was doing prostate biopsies was considered a non-necessary or absolutely a regular an entity or a procedure that could be doable during the whole COVID piece. So there's a fair amount of backlog that went in. We got a fairly streamlined, identified path to regulatory approval. As I mentioned, the insurance reimbursement codes and the CPT codes for all these things exist. Of course, there has to be value for the patients, the physicians, the hospitals, and the payers. We now have professional management that's going to be coming in. That's been there, done that kind of guys, and it has a broad following among some of the internationally recognized experts in this field. And of course, with that said, we think we've got a pretty good opportunity to have a successful run here and get to a graduation date at a fairly early date. Now, we don't have a financial model put in here. Be happy to share all that stuff in profound detail. I'll share with you that the preamble is 11.5 pages long. It goes into it. We believe in doing bottoms up approaches. So now you can't just take percentage of market share and go plop it in. How are you going to get there? Who's going to do it? What's it going to take to do it? What's the timing? How likely is it that you're going to have people that'll actually be able to get it positioned? What is the pathway? Is it going to be through the pathology department? Do you have to go through the general procurement process? Does this fall into the large CapEx category where you got to go through 18 months? And all those things have been given careful consideration to. Although I don't think we have this slide up anymore, that got cut, but we have a comparison analysis of the competitors and what the prices are. And all in, we're going to be about $25,000, between 20 and 25,000 for a individual facility to set it up, let alone what they call large group practices, or the acronym is LUGPAs, versus somewhere from a low of 125,000 up to 500,000 to have competitive piece of equipment. I don't like big, capital intensive businesses because they're too difficult to, to execute a sales plan around, let alone keep the margins at +85. They'll have 3 different disposable items that are attached to it, and 1 non-disposable, i.e. the biopsy device, which is manageable. And we're going to bring that out very slowly. And we've already got version 2, 3, and 4, 5 in mind, but bring those out until you've got good track record or traction with the current version. 19, please. That brings us to you, Arthur, and any questions anybody might have.
What's this look like in terms of the cost of presently using the existing device? Is it about the same cost?
Yeah, our project will be coming in right on top of it's going to have a little bit of a premium to it, but not much to what the current market really is. And we don't believe in pricing. We don't use the Walmart or the Cargill pricing strategy. We're going to sell on value. And we know there's enough demand for the needle alone to drive the whole enterprise value here. And that's, by the way, those needles are disposable on after each patient, not each needle stick, but after each patient. They're not, reused then for the next patient. They're not cleanable or sterilizable.
So the CPT codes will dictate the reimbursement. So what you're suggesting is it's going to be in line with that, right?
Yeah, it'll all fit within those lines. So they'll get it. And if an individual physician decides to charge more value for this, he could either run this thing on a competitive basis with those other current cost structures are, or he can use it as a loss leader and charge a higher premium rate because he's ultimately going to find more opportunities to either treat the patient over a longer period of time with follow-up and focal therapy, or make the patient happy because he can tell them with good conscience to go home, don't worry about it. You know, you're going to, when your time comes, it's going to be a something else.
Yeah. So
There's a hidden value add here for just the lack of anxiety that, you know, tends to pulse through every man's, you know, basic being when he gets the diagnosis.
yeah, yeah, there's anxiety associated with that, no doubt. So
Sure.
you've seen this movie before. I know you have, many of us have, and I'm not suggesting that you know this outcome, but is this likely to be, okay, guys, you proved it out. Here's a big check. Let's go, you know, in the fourth quarter of 22 from the medical device community?
Well, it could be, but I'll tell you, you know, this is our own internal work now that's being done. The exit values for these things are a low of 20 times sales and a high of into the 40s, somewhere between that, you know, sweet spot of about 20 million on a run rate in sales to 40 to 50. They don't tend to get that big beyond that. And, you know, for those that haven't worked in the space or invested with the rest of us, why in the hell would someone pay something like that? It's quite simple, because they can take that now developed, approved, you know, they've got the manufacturing piece figured out, product, got all the costs out of it, and plug and play into their worldwide distribution system, particularly if you've got approvals to go in these various different markets, and they can, you know, drive up sales dramatically very quickly. And if you've got something that has already got a premium price to it, where they don't have to worry about price pressure, they become very valuable.
Yeah, the COVID situation has seemed to work in your favor, aside from the negative part of being delayed, but you're riding on the back of a quicker approval.
Well, not only a quicker approval, but there's a lot more shall I say, pent up demands, because a lot of men didn't get their, you know, frankly, they weren't able to get in to get a biopsy done.
Yeah. Super interesting. So we had a question about burn rate and balance sheet, but you can save that for talking directly, and I'll share with you who asked that question when you can connect directly with the folks that were on the call. So super interesting. Great. I love I know nothing about this stuff, and Jason will attest to that, but it's just from just a logic view, that having those ridges, like, it makes so much sense, right? And then what you were saying about the ability to take the data and then create a scan that makes it, because it seems to me like what you were saying, Fred, that the ability to map out the organ, that's just going to get better and better and better based on how much data you have, right?
That's correct.
Yeah.
And then new treatment opportunities are going to be coming on. Eventually, Arthur, I think that, and to our audience, immunotherapy is going to become a much more widely used platform. And to really know that, you got to know exactly what you have and what the species of it is, so they can tweak the treatment specific to you, to me, or to whomever.
Makes so much sense. So if it's okay with you guys, we're going to make sure we put everybody in touch with you. And then, as I suggested to Jason, in the next few weeks, let's go ahead and have a different version of this to talk about not just the money raising part of it, but the impacts to the society of what you're doing, because it's significant. Is that all right?
Yeah, great.
Fantastic.
Yeah. So thank you guys. That was really awesome. I don't know why you didn't introduce me, Jason, to Brad earlier. I wrote you a private note, and you know why I said that. So thank you. And it has nothing to do with you, Paul or Fred, by the way, and Todd. So, so thank you all for being here today. And if there's anybody you think in your community that would be interested or benefit from hearing about this, please let us know. We'll make sure that everybody gets in touch. And as I always say, thank you for spending the only thing you can't make more of, and that's your time with us. Till next time, take care.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thanks, guys. Bye.
Thanks.